Early morning. Thanks to all the audience. I'll before we start the IC, I'd like to call my co-panelist, Brigadier Varanwal and Vijay. Aja. Okay, we aja. So we are in time, yeah. So all of us, why we had this IC is all of us we deal with trauma in our life, in our residencies. We have done it as faculty in government hospitals. But whatever we do is very hurried, and basically we are looking at only eye trauma. However, when it is trauma, it is never a single eye involvement. It is a multi-organ trauma. Multiple things are involved, and what we are going to speak about and talk about in this trauma, this thing is how do we do it in armed forces? Because probably we are in a unique situation where we are dealing with maximum trauma, which is polytrauma. So we'll just go through it, and since we have evolved some standardized protocol, we'll just discuss those protocols. So probably I'll only start. Live in a country which has got a varied landscape. It's a huge country. If you start from north and northeast of our country, there are hills and there are mountains. Once you have mountains, you have places where there is snow, there are forests, there are now you have rivers in between. Now, imagine a person getting injured somewhere in on top of a hill. How do you treat that person? How do you evacuate that person to a higher center? How difficult it is for people in far-flung areas to get adequate treatment. So this is what we'll discuss in this thing. Now the country is not only hills. If you come down to the lower part, the southern part of the country, we have the waterways, the large rivers we have, and then we have the what do you call it? The open sea. Now again, imagine somebody on a ship, he gets injured. How do you treat? So these are the things which probably will cover in this session. So we have a tri-service medical services which involves medical services in Army, Air Force as well as Navy, and that is why we are probably a unique service in this country. So we in armed forces we have got unique exposure to high altitude area in north and northeast of our country. Then we have a large coastline extending from Gujarat to West Bengal. Again, this is again where we treat and where we have challenges in treatment of patients. Then northeast we have thick rainforests. Again, imagine somebody having injury here. How do you take that person out, and how do you treat it at the location? Then northwest of our country we have deserts. Again, unique situation, unique kind of trauma, unique issues. We have a large airspace. Now, disclaimer is this is all public info. We are not sharing anything confidential. Again, we have large airspace where again our air warriors are involved and they are exposed to unique things. So once we see this varied topography, there is no one-stop solution to the casualties because the topography is very varied. Far-flung areas, casualty evacuation is very difficult, and this is where we probably will have to bank on local management, people who need to be trained for trauma at peripheral levels. Another thing is we have limited manpower over a huge area, and the clientele it is very vulnerable to trauma because when so many people are involved in explosives, again in what do you call it, terrorism, and so much movement of the men and the explosives, you have chances of injuries which are very high. Unique injuries which nobody else will see, IED blasts, thermochemical injuries, projectiles which other people don't see. Then again, terrain specific trauma like hyperbaric trauma, high altitude related frost bites. All these things are again very different, and high altitude involved injuries to the retina. So what we have devised is we have devised something like standard operating procedures where we have these four pillars of our treatment. One is echelon based medical support system. We'll come to that. Training of manpower, even men in periphery who are non-medical, they are trained. Then we bank on telemedicine and robust casualty evacuation system. What is echelon-based medical support system? At every level, everybody is trained. They have kind of equipment where you can manage trauma. Now, if you see from periphery, which is the peripheral level, you keep treating patients and evacuating patients depending on what kind of injuries are there. And highest surgical capability is definitely care at the level 4. So this is what echelon based medical support system is there. So at peripheral post we have non-medical people which are called BFNAs. They are the guys who treat patients. They have basic training facilities, and some places we have nursing assistants and medical officers. Equipments what they have is sat phones, basic first aid, and they're trained for basic life support and advanced life support, both are things. Now, next is the static places, which are probably secondary care centers where surgical teams are there, and few places you have ophthalmologists and they have capability of basic surgery. And again, they can be mobile, they can be static. Next is the zonal hospitals, which are static, which have got surgical teams. We have ophthalmologists in all zonal hospitals and few subspecialties. We have support of neurosurgeons as well as maxillofacial support surgeries. Then tertiary care centers at line of casualty evacuation, which they are the final places where people are treated. And their evacuation is done, they are the referral centers and all subspecialties are available. So these are the tertiary care centers which we have. What happens in multiple organ trauma? Now, most important thing is what is told is once there is a injury, once there is a trauma anywhere, that area has to be secured because there are chances of secondary injuries in those areas. This is how people are trained because these are sites where you can have fire, debris, secondary blasts. So if somebody's been there, they'll know about these. Then first responders are trained for this airway, breathing, circulation, disability, exposure, and now we call it uh, casualty care at terminal level, which is the casualty calculation. And again, the surgeries are life and limb saving. First responders are told about securing the spine before evacuation, especially before movement. Then all first responders, if possible, if there is eye injury, vision, RAPD, and if there is an open globe that has to be seen, eye shields are given, and these are the basic treatment which is done before evacuation of patients. We have secure networks at peripheral levels, which are our service specific networks. Again, telemedicine can be done on these with high speed internet and sat phones, which is there. And again, at places we have these handheld fundus cameras and handheld cameras where a teleconsultation can be done at the higher centers. And again, these kind of things are available in most of the posts where, again, talk can be done and we can get a basic guidance from ophthalmologists or the other specialists. Casualty evacuation is one very difficult part where you sometimes it has to be done on manpack, sometimes on vehicles, sometimes on helicopters. This is something called a PTU, patient transfer unit. Again, it is used for evacuation of sick patients. And again, multiple modes of evacuation is done to take patient to the higher centers. At higher centers, again, multi-organ trauma, you do EUA, multi-speciality team is involved. So again, maxillofacial trauma, very common with ocular injuries, combined effort is required. Head injuries, again, it is important to look at pupil, cranial nerve involvement, muscle paralysis, and other issues which happen with head injuries. And it is usually a combined effort with neurosurgeons. So in nutshell, we have to anticipate what is going to happen to these patients. We have to assess our area of responsibility, take stock of manpower, medical resources, and accordingly calibrate and plan our response and make standard operating procedures according to the place where we are staying. And we need to have a planned evacuation routes with us only. And the most important thing is training everybody who is involved in patient care or where injuries can happen, because every second invested in training saves a life, limb, or eye. Now, in continuation, I'll call Brigadier Baranwal to speak about ocular injury specific to armed forces. बोल दिया Excuse me. Slideshow.
Thank you, Brigadier Sandeep Gupta, for including me in the IC. I'll talk about ocular injuries which are specific to the armed forces. As has been told by Brigadier Gupta, ocular injuries are not uncommon in wars, and these are usually associated with multiple injuries. Sometimes when the patient has multiple injuries and maybe unconscious, the evaluation may not be possible initially, and protection by the ocular protective goggles is very important. We are presenting our experience of managing ocular injuries in war or war-like scenarios for last 27 years, which includes the Kargil War, tenure at Republic of Congo, and at Command Hospital. Uh, the why the ocular injuries are unique in armed forces, because first of all the mechanism of injury, uh, as compared to the civilian trauma, because of the domestic accidents or the road traffic accidents, the armed forces injuries are mainly caused by the blasts, splinters or IED blasts, landmines, and as expected the projectile velocity is very high. As been discussed, it is usually associated with polytrauma. The wounds are and the injuries are highly contaminated. Evacuation is difficult, often delayed and staged. In addition to the injury, there is combat stress which also has to be dealt. The common modes of injuries in ocular injuries are blast related injuries. The primary blast because of the pressure wave, secondary blast because of the sharpness of the foreign bodies, tertiary blast because of the bony displacements leading to orbital fractures, and the quaternary blast because of the burns or chemicals. Penetrating injuries, the most common penetrating shrapnels or the splinters are made of steel, copper, aluminum, or even in the IED blast the stone fragments have been noted. Their size is small and speed is high. They are usually located in the posterior part of the eye or in the orbit. Gunshot wounds were much commoner earlier, now they are less common. They cause cavitation and destruction of the eye ball, which is difficult to protect by the goggles. Next is the chemical warfare injuries, radiation and laser injuries. In fact, yesterday I was seeing the TV, they said the laser are being used during this Iran and Israel USA conflict. Last but not the least is the high altitude and the environmental injuries. This patient, you can see, has been injured by the bear while he was located in the high altitude area. Field management protocol has been discussed by Brigadier Sandeep Gupta. At the site of the injury, normally pressure bandage, rigid eye shield is given, no pressure patch is given. In addition, IV broad spectrum antibiotics are given, and if open globe injury is suspected, then ointment is not applied. We try to evacuate as early as possible, and at the primary center where the ophthalmologist is available, primary repair is done. CT scan of the orbit is mandatory in most of the cases if you are suspecting a intraocular foreign body. A comprehensive initial assessment by a team is very important because it helps to form an integrated treatment plan, and number of surgical interventions or the GAs which are required for the patient are decreased, and in addition there is efficient resource utilization. Uh, Bow and arrow injuries, which we think are outdated, but it is still being seen in many parts of the world. You can see a bow and arrow injury, and this is the result. This is not uncommon in some part of the world. Various injuries we can see are dislocation of the lens, vitreous hemorrhage with intraocular foreign bodies, many of them, PVDs, choroidal detachments, retinal detachments. And now coming to the injuries which are more commonly seen in the wars or the army scenario are splinter damage. Multiple splinters can be seen in the eye, which are damaging the eyeball. multiple foreign bodies are located on the eyeball, inside the eyeball as well, a single intraocular foreign body. Orbital fractures, you will see different types of orbital fractures involving the lateral orbital margin, inferior orbital margin, various types of fractures. Some unique cases which we have seen is this was a case the patient reported with a splinter injury. Luckily, the eyeball was absolutely normal. He was seeing well. We resorted for a CT scan and saw a foreign body lying out just outside the sclera. You can see on the posterior part of the eyeball. Obviously, removal was much more difficult than this, and being inert foreign body, he was left. Nothing was done surgically, but these types of patients they need to be followed up regularly. Another this case, young Sikh soldier, he came to us with sudden diminution or sudden loss of vision. Everything, eyeball was absolutely normal, everything was normal, but he said that he is not able to see. We did X-ray and found out a foreign body out here. CT scan was done, which showed the optic nerve has been transected. Obviously, there is nothing we can do, but these types of things, I think. This patient, he came with a splinter injury entering through the side of the orbit, injuring the eyeball and then lying on the optic chiasma. These type of foreign bodies are in fact very difficult to remove, and if required, help of a neurosurgeon is required. This is another injury, intracranial fragment. When we were during the Kargil war, large number of patients, casualties they had come. This patient, we did a X-ray and could not get a CT done because other patients they required CT urgently. We tried to, eyeball was shattered, we went in for the evisceration. Unfortunately, during evisceration, we could not locate the foreign body. Then we later on we took him for a CT scan, which showed a foreign body which is partly intracranial and partly intraorbital. It was removed with the help of the neurosurgeons because we were lucky that if we had tried to remove it excessively during that time, coning of the brain could have occurred and patient could have died. This is a foreign body which has injured the medial rectus muscle. To conclude, there is a high rate of combat eye injuries. Advances in weaponry has increased and changed the type of eye injuries. CT scan and ultrasound are of utmost importance for scientific management. Key differences we have already discussed. Thank you so much.
Thank you, sir, for covering and probably highlighting that the kind of varied trauma we get which others don't get. Next topic I'll like to call Dr. Ashutosh Gupta, who's an accomplished VR surgeon, for covering the topic management of posterior segment trauma.
Thank you, sir. In the next another 10 minutes, I am going to talk about something which we practice in armed forces. The aim of presentation is generally the trauma management principles remains the same, but sometimes how we manage the case, it makes a difference. So in another 10 minutes, I'm going to show few videos where how we manage the cases related with the ocular trauma. The primary repair, what we do earliest as soon as patient reaches us. In every cases, If there is open globe injury, we give intravitreal antibiotic, and our preference drug is Vanco and Cefta. If there is no signs of any infection, we start with oral steroid, and we prefer CT imaging as compared to ultrasound. So my today's highlight are managing giant retinal tear, IOFB, and traumatic drop dial. First case, 25-year-old serving soldier, he sustained injury. Now I will talk on mainly on the video part. When he reported to us, there was 270 degree of giant retinal tear. If you can see in the video, the retina was folded on itself. So 25 gauge pars plana vitrectomy was done. Here care has to be taken not to damage the detached retina, because the retina is very mobile in such a cases. So after that, after doing a complete vitrectomy, triamcinolone was injected to find if there was any posterior vitreous left. PFCL is called as the surgeon's third hand in case of GRT. So PFCL was injected to unroll the rolled retina. But issue in this case is it's because it's 270 degree, it's not easy to unroll the folded retina. So first, with the help of cutter, it was tried to unroll without damaging the retina. Followed by, I have used the soft tip. Even soft tip cannula can be used to unroll the retina. Even with this, when it was not happening, I have used the micro forceps. So we can use the micro forceps to unroll the retina. But every time we have to take, it's really a delicate structure. So as much as less damage if we can do, that's give us a better result. So once the retina was unrolled, I have injected PFCL mode to completely unroll it, and then 360 degree endo laser done. Now we can appreciate the retina is attached, followed by siliconal endotamponade was done. Now another case, 30-year-old male, same history of trauma, but here the GRT was just 120 degree. So their management is a little bit different as compared. If the GRT is more than 180 degree, then we don't put adjuvant band. But if the GRT is less than 180 degree, we put the adjuvant band. Here, a modified technique of putting the adjuvant band, we call it a sutureless. We don't put suture. We pass via the scleral tunnel. The putting the adjuvant band, the advantage is that they give support to the vitreous patch where the retina is attached. So in future, the chances of recurrence is less. After that, 25 gauge pars plana port placed, vitrectomy done. Triamcinolone injected. We always, in every case, we inject triamcinolone to find if there is no posterior vitreous left. Here also to unroll the, I have used the soft tip. Then 360 laser is done. And in the last, silicone or tamponade was given. Coming next to the intraocular foreign body, I will show you some cases where how I have managed the intraocular foreign body. And there are a few innovative steps in that. It's going to help the audience. Young boy, vision 6/6, with inferiorly there was a small intraocular foreign body, and patient was phakic. So the first problem is like to induce the PVD, but we have to do complete vitrectomy. After that, we can remove the intraocular foreign body. So with the help of soft tip and microforceps, foreign body was removed from the pars plana route since the patient was phakic. Second case, this was a case of OGI with foreign body with end off. So we have done all the primary repair and everything in the same sitting. So first, the corneal laceration, it was repaired with 10-0 nylon. I don't use AC maintainer, I use 25 gauge port in place of AC maintainer. After that, PPL was done since the lens was cataractous because foreign body has gone through it. There was end of thick vitreous exudate. I tried to find the foreign body. It was present in the CT, but till now I was not able to find. Generally, we don't induce PVD in case of end off, but my main aim was to find the foreign body to remove it. So gently PVD was induced, not damaging the retina. After removing, I found the foreign body. So vitreous was trimmed around the foreign body, and with the help of forceps, it was taken out from the place. Then I have used intraocular magnet to lift it and remove via the limbus. Laser around the place where it was lodged was lasered, and though there was no retinal detachment, we have given silicone or tamponade and intravitreal antibiotic was given. Another very interesting case, glass foreign body. It's very easy to remove the metallic foreign body. Phakic patient. Here we can see there was a glass foreign body. So I planned it remove via the after removing the cataract, this clear lens. So after making capsular access, lens was aspirated. Since the patient was 19-year-old, it was very easy to do with the IA cannula. Vitrectomy was done. PVD was induced. PFCL was injected to protect the macula. And this glass foreign body was really large, and we can't hold with any forceps. That is the problem. So after clearing the vitreous and making it free, here I've used the soft tip to lift the. Before that, I'm making this posterior capsulotomy. So the glass foreign body was lifted with the help of soft tip active suction, and it was brought via the capsule. Again, the precaution was taken not to damage the capsule because my plan was to place the IOL. So after bringing in the AC, it was removed via the limbal incision. And 3 piece was placed in the bag, though there was no posterior capsule in the center, it was deficient. And the laser was done. And patient gained 6/9 vision. And thank you, my time is over. Now I call the next.
Till we call Dr. Rishi for his presentation, one small query. Ashutosh, a query from you. In this last case, since capsulectomy was done with a vitrector,
Yes, sir.
how stable is the capsule after doing a capsulectomy with a vitrector?
So it's quite stable.
Quite
I've
stable.
used in so many, it doesn't extend and it's quite circular.
So,
I've used,
another
even
one.
I've used in doing anterior capsulotomy. Sometimes in case of pediatric cases, I've used cutter to make the anterior capsulotomy and it's quite stable, sir.
So one small suggestion: if you do it with the forceps, it will probably be even more stable and more this thing. Yeah.
Sir. Thank you, sir.
I'll call upon Dr. Rishi for his presentation on management of orbital and adnexal trauma.
Good morning to you all. I'll be discussing about the orbital and adnexal trauma. Orbital trauma can damage the facial bones and the adjacent soft tissues with multiple injuries to the contents, to the intracranial structures and the paranasal sinuses. The epidemiology as such of the orbital fractures, we have about 78% of fractures being involved with orbit involvement, foreign body 24%, hemorrhage 1%, and generally 78% males. Usually orbital involvement is seen in 15% of all serious injuries. Just a glance through the anatomy, the bony orbit, the walls, the arteries, the nerves, the contents of the orbit. The anatomical space bounded superiorly by the anterior cranial fossa, laterally by the middle cranial fossa. It's 30 ml, 7 bones, maxillary zygomatic frontal. This is the roof of the orbit, the various 4 walls being formed by different bones. Now we come that orbital trauma is divided into as bony and as soft tissue injury. Soft tissue injury is further into eyelid and lacrimal apparatus injury, orbital hemorrhage or intraorbital foreign body. Or you have bony orbital trauma where the simple fractures or associated with facial fractures or skull fracture. The basic pathophysiology is that there is a trauma, there is a thick rim which protect the eyeball. They absorb the shock by fracturing themselves, especially the posterior medial wall and the floor. They get fractured in an isolated way, so there is displacement either inwards or outwards, so it's a blow-in or a blow-out fracture. These are the classification of a Lee-Fort mid-facial fractures. Orbital fold fractures generally by the history, the physical examination and of course the radiograph, and the isolated floor blowout orbit is the most common fracture, and the location is posterior middle floor. This is an orbital roof fracture depiction. This is a 24-year-old man who was trying to secure a pallet with a tied-on chain. This Fortunately, the eyes were not much involved, and the CT showed a massive naso-orbital ethmoidal disruption. But however, there was a multi-speciality involvement required, and early surgery led to better results. Orbital hemorrhage after chest compression. The NOE fracture is a result of the high energy trauma that infects on the central midface. The tripod fracture is the orbital floor fracture, the fracture of the lateral wall of the maxillary antrum, the zygomatic arch fracture, and the widening of the zygomatico-frontal suture. The orbital hematoma, it takes place because of the poor vascular perfusion of the nerve and the retina, gray vision, proptosis, ecchymosis, a subconjunctival hemorrhage, and an RAPD with a hard globe. If the pressure goes uncontrolled, it can lead to orbital compartment syndrome, which will require a lateral canthotomy and a cantholysis. Intraorbital foreign body. There are multiple foreign bodies which are seen in this as a result of a 21-year-old soldier who was standing to a campfire and had a M16 blank ammunition. The foreign body was removed, there was no complications. Generally, however, the metallic foreign bodies can be left in the deep orbit alone. What are the signs for a intraorbital foreign body? Visible site of entry is absent, there is pain, there is impairment of vision, there can be limitation of movement, a proptosis and fundus findings. Foreign body should be removed in case it's a vegetable matter, easy to access, a copper, iron or zinc. They can be observed if it is inert, has smooth edges, and it is located in the posterior orbit. Broad spectrum antibiotics and tetanus toxoid is warranted in all cases. What should you do if you have suffered an orbital trauma? Avoid touching your eye, seek medical attention immediately, and possible multi-speciality treatment is required. This is just a flow chart showing how you manage the orbital trauma with orbital fracture. If there is a loss of vision during traumatic episodes, then you have to go in for a conservative therapy if the vital signs are unstable. Significant oculocardiac reflex, then immediate surgical repair. A delay repair within 2 weeks in case there is no pain on movements. A surgical intervention is required when there is pain on movements, diplopia, and extraocular muscle limitation. Surgical management, the orbital fractures generally require the specific indications of restricted strabismus, the CT evidence of mesial entrapment, an ophthalmos less than 2 mm, oculocardiac reflex, a transconjunctival approach. This is a dichromatic representation of an orbital floor fracture repair. Next we come to another important thing, that is a traumatic optic neuropathy. It takes place in about 0.5 to 5% of the head trauma, 2.5% of the mid-facial fractures. There is contusion deformation, types, indirect and direct, and sometimes compression related. Diagnosis, clinical, history of trauma, pupillary examination. Management generally is observation. A few cases are self-resolving. However, there can be visual recovery which might be variable. So early evaluation and intervention are required for optimizing the visual outcomes. There is something known as a CC scatter, which is just an abbreviation for command, control, safety, communication, assess, triage, treatment, transport, decontamination if applicable, exploit and recover. This is just a general protocol which is followed in the armed forces as such for managing a trauma case. Basically, it points towards that a multidisciplinary approach is required. The coordination between the trauma should be there at all levels, and speedy evacuation and early treatment in selected cases. So injuries to the orbit can be associated with severe neurological injuries, which can be life-threatening. So they take precedence over the orbital treatment. History taking is important, as already discussed earlier. A nature of object, there can be a trauma to the nerve, acute epiphora or rhinorrhea. Patient with an orbital trauma comes to you, primary survey, we follow ABC stabilization. We assess the vision, pupils for the RAPD. Is the globe ruptured? Yes. Then you require an eye shield and an urgent surgery. If no, you evaluate for a CT orbit and adnexa. You evaluate the findings. In case the CT shows fracture, that is entrapment, diplopia and large defect, you require a surgical repair within 1 to 2 weeks. Evaluation of visual functions of paramount importance. CT and MRI, we can, based upon the soft tissues delineation or whenever there's suspected orbital fractures. These are multiple cases of eyelid lacerations, which form a bulk of the ocular trauma seen in the A&E. So in lid injuries, generally primary repair is the best to be followed, gentle handling of the tissues. So they say that the primary repair is the best option. Repair the deep tissues first. So this is a case of a 6-year-old boy who had sustained injury to the left eye. and post-operative picture is placed next. This is another case of a serving soldier when he slipped in his unit lines and fell on a sharp stone. He had an avulsion. This is the pre-op and the post-op photograph. This is another road traffic accident to a serving soldier. He got hit against the dashboard. There were multiple lid lacerations and facial injuries which were managed. This is a 7-year-old boy. He had a trauma to left upper eyelid. Again, being hit with a branch of a tree while playing. We'll skip the lacrimal apparatus anatomy. So we have the blunt trauma, the penetrating trauma, dog bites and facial fracture, out of which the canalicular injuries are most common. Clinical evaluation, again, history of trauma, examination and fluorescent dye test. Management, the principles are restore the tear drainage, prevent epiphora, early surgical repair. So just to conclude, for wartime orbital trauma, there is a multidisciplinary team required. Ophthalmologist role is crucial. The emergency response, the protocol should be in place. There should be surgical interventions and the timing is very critical. And of course, high level of expertise and coordination amongst all the medical personals. I'm through with the presentation.
Thanks, Rishi. If there is any question, till the time Dr. Vijay comes up and places his talk, any questions to Rishi, you can have it.
Sir, I had just covered because I had multiple things to be covered. I would have definitely told about the optical nerve avulsion. But what do you want to know in that, sir?
No management.
Diagnosis to management, sir. Management optic nerve avulsion has no fixed management as such, sir. And optic nerve avulsion is, sir, if you can further.
Zero management. No PL, and usually what you do is initially the kind of trauma you have is you have to have whenever you have no PL, you have to have very high index of suspicion of after a trauma, and then usually whatever cases we have seen is there is a pit kind of thing in the this thing very empty pit. Again,
It will be more common in a blunt trauma rather than an open globe. No, not the pit. It's available. It's seen as a black area where the disc should be. It is not visible. It will generally be more common in a blunt injury where the impact results in a coup counter coup injury, where the movement of the eye is so much front and back that the disc avulses. It won't be common in an open globe injury. It will be in a blunt injury with a coup counter coup mechanism typically.
Ma'am, first with, ma'am, dosage, so you can give a initial intravenous dose as well, but it basically depends upon the degree of inflammation. As I said, if there is multiple involvement in it, you can go in for a steroid, but if there is a early repair required, you go for surgical intervention then. Otherwise, steroids can be used, but there is no fixed role as such. If you have a orbital floor fracture, you will basically go for the surgical management if required. Otherwise, there is only conservative management which is there. Does not know specific steroid or as such. It can even be with an NSAID only just for pain relief. Steroids particularly are not targeted in. Yeah, if definitely if there is an optic nerve involvement, definitely you'll have to go in because that is what the NASC study also says that within 8 hours of sustaining an injury, you will require IV steroids to be given. Otherwise, as such, no fixed role for steroids. Then to steroids, if they're actually pertinent to be used, then you'll use. Otherwise, you'll have to go for the systemic status of the individual. You can give a shot because there's no problem, but probably a pulse dose therapy as we give in TUN, that can be given because that will take precedence over the diabetic status of the individual. Otherwise, you will try and avoid steroids if possible, especially if it's an uncontrolled diabetic or this thing.
see, ma'am, if steroids are absolutely indicated, if the indication is absolute, then any diabetic can be shifted to a sliding scale insulin and steroids can be given. There's no harm in that.
Normally, madam, steroids are given when the optic nerve compromise is noticed. Otherwise, we have to see and what are the indications. Most probably optic nerve, once it is compromised, then yes. Methylprednisolone as this has to be started, and the surgical intervention, if required, has to be done.
Request Vijay to
Thank
start
you.
his presentation.
Thank you, sir. So I'll be speaking about management of corneal scleral laceration, what protocol that we follow in armed forces. So usually we follow with the Birmingham eye trauma and terminology system. I'll be covering predominantly the lamellar laceration, the rupture, and the penetrating, perforating or intraocular foreign body part of it. So based on this, we classify our any patients who comes to us with open globe injury. We classify as per the type, whether it's a rupture, penetrating injury, intraocular foreign body, perforating injury, or a mix. Then based on zone, whether it's a cornea and limbus is involved, from limbus to 5 millimeter posterior to sclera, and posterior to 5 millimeter. Then third is based on the grade, depending upon the presenting visual acuity, and also the pupils, whether there is a pupil positive or a pupil negative. Then the OTS is very important. So ocular trauma score is very, very important at the initial examination. So based on the visual acuity, we assign the score. If the visual acuity is better than 612, then a score of 100 is assigned. And similarly, based on different visual acuity, different scores as mentioned in the table are assigned. Now, along with that, if there is a rupture, from that total score that we have assigned based on the visual acuity, that much points are reduced. For rupture, say -23, for perforating injury -14 from the initial score based on visual acuity, and a final raw score is calculated. Now on the raw score, now you can see the sum of raw points. Based on that, now there are categories for the ocular trauma score. Now these categories are category 1 if the score is 44 or below, and category 5 is 92 to 100. Now this is very important for prognosticating a patient about the what prognosis he'll have as far as the visual outcome is concerned. If the category 1 is there, then around 74% chances are there that the individual will have no light perception vision. But if the vision is better than 612, then only 1% in the category 1 can have a vision of 612 after the primary repair and the secondary intervention. So, so this BETS classification and ocular trauma score is very, very important to assign to the patient. Now, the corneal lacerations are now divided based on the thickness of corneal involvement, whether it's a lamellar or a full thickness, or based on complexity, whether it's a simple corneal laceration or a complex corneal laceration. Simple when there is no tissue loss, no involvement of other parts of eye, whereas complex is when there is significant tissue loss as well as involvement of other ocular tissues. It's important, now these parts have been covered, that at the time of history we have to find out the date, time and location of the injury, mode of injury, what object has caused trauma, and evaluate risk of any microbial contamination at that point of time. Clinical evaluation is very important. Two most important parameters that one should check is the visual acuity and the presence of RAPD, because these are the prognostic factors. Then signs of occult laceration. Now these are some signs of occult laceration. If there is a chemosis, it can hide an underlying scleral laceration. If there is a subconjunctival hemorrhage, it can hide that laceration. So similarly, you will, or a vitreous show or a prolapse, that should be evaluated at the initial examination. If there is an irregular anterior chamber, again, these are the signs of occult corneal scleral laceration, and these will help while managing the laceration. Then it's important to do the investigation. The most important investigation is the CT scan. You have to avoid the MRI for any metallic foreign body, but CT is must if there is a corneal scleral laceration and where you are suspecting an intraocular foreign body. So how do we repair? Now primary repair is the most important. Restoration of normal anatomical relations is very, very important, and then you can take up the secondary repair subsequently depending upon how the case progresses. Some important aspects: identifying anatomical landmarks, identifying limbus, sharp edges, stellate edges, or a posterior margin of scleral laceration is important. Suturing in the central part, you have to do the suturing, small sutures slightly wide apart. In the periphery, larger sutures closer. So that should be the aim of suturing, especially for the corneal laceration. And also, you have to see whether the laceration is perpendicular or a beveled. If it is a beveled laceration, the posterior part of the bevel laceration should be divided into half, not the anterior part, to avoid any beveling of edges when the healing occurs. Now let's see some cases. There is one case where there was a corneal laceration and also with a sharp object, and also there was bisection of the lens. The vitreous was prolapsing. So you have to remove the vitreous from the wound margins first, and then you can go ahead with the suturing of the corneal laceration. Whenever the lens is disrupted, lens capsule is disrupted, and there is some cortex which has come into the anterior chamber, you have to do the cortical aspiration. The IOL implantation can be done at a later part. Now this is another case where there is iris prolapse at the limbus. Now it's important to look at the wound for any foreign body. Like in these cases, there were some eyelashes which had gone there. Then you have to remove, you have to dissect the conjunctiva and tenon very carefully to expose any underlying scleral laceration. It's very important. You can expose that, and then the first suture should be given at the limbus, then corneal repair should be done, and the scleral repair. So I'll just explain that in the subsequent slide. So now this was another case which we had in the last week only. Now this was a soldier who was traveling in a private vehicle, and he had an injury, bilateral corneal scleral laceration. So the diagnosis was made as an open globe injury, both eyes. Tie was mixed because there was a penetrating as well as perforating injury. The zones, zone 1, 2 and 3, all zones were involved. There was no perception of light at that point of time, although the individual was semi-conscious, and pupils could not be assessed. If there is a bilateral injury like this, where is iris and uveal tissues are prolapsing, you cannot assess for RAPD in such a case. So the OTS score in this was 16 in both eyes, and it was classified under OTS category 1. And there was as a prognostic factor, only 74%, there are 74% chances that there will be no perception of light after the primary as well as secondary repair. Now the medical legal case should be initiated in such a patient. The CT scan should be done, and a high risk consent for evisceration should be taken before taking up the patient for surgery, because you never know, you may end up doing evisceration during the repair. So examination is very important. You have to be very careful, no pressure on the globe, because already there is such an extensive laceration that that can cause the prolapse of all the contents. You can do a canthotomy that will relieve the intra-orbital pressure. And now you have to do very carefully the dissection of the tenons and the conjunctiva, and just do so that you can expose the sclera, and then only you can see all the landmarks which you have to suture. So now this patient had on both sides the scleral laceration, and okay, now initially we try to do the limbal suture with a 10-0, but the suture was breaking because pressure was very high. So we had to do the limbal suture, first limbal suture with a 8-0 Vicryl, and we could oppose with that. Now once the one side of limbus is opposed, similarly the suture is applied on the other side, and then you oppose the other side limbus also. Now there are some rules for the corneal laceration repair as well as the scleral laceration repair. The cornea is always sutured by dividing it into halves, and the sclera is suture as you go. Whenever you keep on going from the limbus away towards the scleral laceration, and keep on suturing. So you can see that the cornea first suture is given in the center, dividing the corneal laceration into half. Then the other halves are sutured by rule of halves. So the central sutures, after whichever, you may find some sutures may become loose over a period of time when you are suturing the other laceration areas. So in that you can definitely replace that in the same sitting, and the suturing should be watertight and there should be no leakage. And thus when the sclera was scleral laceration, try to find the posterior X then. Now in this the muscle was already detached, so we could not identify actually the muscle. So we continue suturing posteriorly, and ultimately we could suture the last part of the laceration, and This is the primary repair that we have done. This is the other eye. Now this eye did not had a linear laceration. There was an angulated laceration. So you have to again suture as the angles, as the limbus, and sometimes you may have to give a purse string type of sutures whenever there is an angulated laceration or there is a tissue loss. You may have to use sometimes the donor cornea to suture. So after the primary repair, the secondary repair is very important, that you should take as per what type of complications you have. If there is a central scar in the cornea which is causing only irregular astigmatism, in that case you can do the corneoscleral contact lens or a scleral contact lens for visual rehabilitation. And there are some surgical options, again that depends what type of injury you have subsequently. Now this was a case where there was a loss of iris tissue, significant loss of iris tissue, where the pupilloplasty could not be done. So here some iris segments could be implanted. So you have to decide the secondary repair based on the type of presentation or type of requirement that you have. And so the individual had a glued IOL at the initial surgery, and also the corneoscleral laceration was repaired, and subsequently he had a big iris defect that was repaired using the iris segments. Oh, thank you very much.
Thank you, Vijay, for a wonderful presentation. I'll request Dr. Gaurav for his talk on management of lens and angle injuries. Again, most of these injuries, they look very sinister, very difficult, but if you give time on assessment and identification of landmarks, so then things become easier. So corneoscleral lacerations, even lid lacerations, the first thing is to identify the landmarks, and then things become a lot easier. So that is how you should approach all these injuries.
Thank you, Sandeep. Now I'll be covering the last part of the talk. A lot of my talk has been made easier by Vijay. He's given the scoring and he's covered the corneal laceration part because there's a lot of overlap between our talks. So basically I'll be talking about basically lens angle injuries. Now the type of injuries we've seen across all the talks, speakers have spoken about it. What we basically get in trauma is traumatic cataract, lens subluxation, you have a dislocation anterior posterior, and an intralenticular foreign body. So other complications which can be seen as zonular damage, vitreous loss, which has all been covered earlier. Now basically the investigations remain common to any form of trauma from anterior or posterior. Visual acuity is the one thing which is most important, because like in Vijay's cases with severe trauma, that is where you make the first assessment of whether you have to save the globe and go in for a repair. And these days 99% of the times you go into globe salvage, because you tend to preserve the tissues. As over the last 2 decades the use of steroids has gone up, the incidence of enucleation and evisceration has gradually gone down. But most of these cases you can salvage, as you saw even in the worst of cases. So these investigations became mandatory. Now the timing of surgery, like he commented, the corneoscleral injuries, you repair the cornea first and then you take a call depending on the visibility, the site of the injury, whether the lens injury can be addressed at the first sitting or not. So generally in presence of extensive trauma with corneoscleral lacerations and prolapse of tissue, uveal tissue, you address the lens as a secondary repair. You do the corneal repair first and then wait for it to settle down, let the inflammation go down, maybe 2 weeks, 3 weeks later, and then you address the lens injuries. Just a traumatic cataract with no other significant finding, breach of the anterior capsule with cortical matter in the anterior chamber, there you are going to have a lot of inflammation, prolonged IOP spikes. So that is where one situation where you need to address both the corneoscleral injuries and the lens injuries at the same sitting. And a third situation arises where you have a corneoscleral tear, a lens injury, and an intralenticular foreign body. There it is a no-brainer, whatever the situation, you try and do all three at the same sitting. So this is generally the principle we follow in these traumatic cases. I'll just show you 2 varied cases. The one on the left, you see, was done as a primary repair. This was done by a surgeon and it came to me almost 3 months later. Now the lens was cataractus, and the problem here was what you saw in the initial part of the video was at the time of initial repair, the iris was trapped in the sutures. So this is one thing that you always need to look at when you're doing a secondary repair. Look for iris tissue which is entrapped, because he would have done it when it was a really bad case. He would not have been able to avoid it. Always swipe it and try and remove these adhesions, because these are going to create problem later on. And the second case was where the corneoscleral tear, and there was a small laceration, break in the capsule underlying the corneoscleral tear. So this was addressed in the same setting. So similar cases, but different management. One in a delayed setting, 3 months later, one at the same setting, and almost similar outcomes. Okay, so this is what a post-traumatic subluxated cataract would look like. Now again, I put these two videos just for the contrast. One was the one on the left seems more stable with a lesser area of dialysis managed easily with a CTR, and the left one almost had 6 clock hours. But this one I had done when I was in a situation where I had no access to CTR, anything beyond a CTR, so I didn't have an option of doing anything. This people would have said you take out the lens or you put in a Sionis and suture it. But both could be managed with a CTR. So basically what you need to remember is the rhexis centration should be done as per the capsule location. So if the lens is subluxated to one side, you shift your CCC so that the lens is centered as per the location of the or the physical shape of the lens, not the centration of the pupil. Otherwise you're going to get an eccentric CCC later on when you center it. And both these patients ended up with a vision of almost 6.9, 6.6 part 1 week post-op. Now this video I have put in just to show you one thing. This is a new technique of chop which we call sickle chop. This is what I have developed. Now the primary advantage, if you see here, once I start the chopping, the first chop is like a standard chop. You separate the nucleus into 2 parts. Now that is where the difference sets in. This is of great advantage in subluxated lenses. This is not a case of subluxation, just to demonstrate. So moment you do the first chop, now you'll see I immediately lift up the nucleus and split it from below, like you use a sickle for cutting, harvesting. So there is no rotation of the nucleus involved, so that puts zero stress on the zonules. So any patient with a dialysis or a zonular dehiscence, this is of great advantage because there is no rotation, no stress absolutely on the zonules. So you just lift the nucleus and it's out. So there is absolutely zero stress on the zonules. Now this I put in, this was actually could have been part of Vijay's presentation, just to variety. Now this patient was it was a very weird case. This patient came to us with redness of the eye. He said he had on-off redness for the almost 2 months. Now if you see, can you see any break in the cornea or the sclera? He just had my history of injury, and there was a large stone lying in the anterior chamber. Luckily the lens did not get damaged. It was just lying in the anterior. We were surprised, we could not find an entry wound. There was nothing visible at all. We explored later. There was absolutely no point of entry which could visualize. So you get these kind of cases in the armed forces where patients are exposed to different kinds of trauma. Sometimes working with some instruments, sometimes working with sharp instruments, maybe cutting something. This was a very weird case, and it took us a long time to get this out of the anterior chamber because nothing else was damaged. So we just took it out with visco. Sorry, I'll just go back. I will skip this. Yeah. So basically the key points for phaco in patients with zonular compromise would be avoid stress on the zonules throughout the case, use capsular dyes, hooks, rings and sutured segments, and ensure a 5.5 or 5.75 capsular access to avoid phimosis and subsequent subluxation. And the capsular access to be centered of the bag instead of the pupil, like I mentioned earlier. And nuclear disassembly rotation must be approached carefully. Attempt zonular sparing approaches, like I said, chopping and the technique of sickle chop, which I showed you. So this removes stress and prevents further extension of the zonular dialysis during surgery. Now coming to the angle injuries, basically the type of injury to angle structures would be iridodialysis, cyclodialysis, angle recession, or a TM tear. Now in various techniques of management of iridodialysis, we all know about this. Over the years, a number of techniques have been developed. I won't go into the details of these. So this is basically the sequence of management of the iris injuries. Basically, you approach it with a flap on the site of injury, and then you pass sutures from the opposite side and you thread it through the iris and bury it under the flap or the tunnel that you have created on the sclera. So basically, this is the sequence of injury, the threading. So double sutures basically pass through, and this is the end result. So you have an iris which is well attached, and you almost 3 clock hours of dialysis, which is now repaired, and the iris is more or less attached in that segment. Now, cyclodialysis cleft generally results from a disinsertion of the meridional ciliary muscle fibers from the scleral spur. The complications related to this are more important because you can get a choroidal effusion, retinal folds, optic nerve edema, engorgement and stasis of the retinal veins, and shallow anterior chamber and a cataract. So basically the imaging techniques that you need to use here are slightly different. You do either a UBM or an ASOCT to evaluate the injury. So it basically has medical management and laser therapy. Intervention should take place within the first 3 months. Basic management is cycloplegic drugs, and atropine is the best possible drug that we can use in these situations. Laser therapy has also been used for a cyclodialysis cleft. It works by inducing local inflammation and seals the cleft by promoting adhesion. So you can use an argon laser or transscleral diode photocoagulation or a defocused Nd:YAG laser. The surgical approaches, non-incisional would be a transconjunctival cryotherapy, or incisional would be a direct cycloplexy, base fixation, or a cross-chamber cycloplexy. Now, lastly, we come to the angle recession. I have not covered this in detail because this is a topic which requires separate discussion, but this forms part of the lens angle injuries that we see in trauma, and especially in the armed forces where you have a large number of serving personnel who take part in sports also, sports like boxing, etc. And a lot of these injuries go unreported. Often patients report to us, he's a full-time boxer, and he reports years later with a raised IOP, and we find he has had some trauma earlier during maybe one of his bouts of boxing, and it results into an angle recession which has probably been missed or he is not reported at all. So it's very common in the armed forces, probably due to their high exposure to blunt trauma, which is very common. So this is caused by a tear between the longitudinal and circular muscles of the ciliary body. Around 60% of eyes with blunt trauma develop some degree of angle recession, and its incidence increases in the presence of increased pigmentation, elevated baseline IOP, and if initially is at an hypema or there is a lens displacement, and especially when there is an angle recession of more than 180, then the glaucoma generally tends to set in. So the evaluation is a slit lamp examination, GAT, gonioscopy to identify the recession, and then the treatment of glaucoma. Generally, what we have seen in these patients, most of these patients fail with medical therapy. Medical therapy in the long run is not successful in controlling these patients. So ultimately, you have to go in for a trabeculectomy, and which has to be an augmented trab in most of these cases. And if that fails, then your fallback option is the glaucoma drainage devices. And in very severe cases, this is a rarity, cyclodestructive procedure. Generally, angle recession glaucoma doesn't reach that stage. If managed medically and then surgery done at the right time, you can manage most of these cases with an augmented trabeculectomy. Yeah. Thank you so much.
Thank you, sir, for covering this topic so well. So we are well within time. And
Sir. That was inferior, sir. It was very difficult to remove it. Visco removal was very easy, sir. It came out from the superior incision.
So, to conclude, I thank all my co-panelists for this lovely interaction. An important thing to note is if we standardize our protocols, if we have checklists for whatever we do, we don't miss things, and that is the way to go forward. And again, some time spent in planning the cases helps us a lot in anticipating what problems we may face during the surgery, and that is how we can manage most of the complications intraoperatively without problems. Thank you so much.